Now, there we go. We're streaming. And I hope everybody's having a great day. God bless you and God bless America. We're here with Dr. Curtis Stark on the Medical Hour. The 30th, or the 29th, no, the 29th of August in the year of our Lord.
No, it's the 30th.
It is the 30th.
It's
okay.
the 30th.
In the year of our Lord 2017.
Date and time, everything, right?
Welcome. Welcome.
Good to be here again.
On that. I guess the first thing right off the bat is, wow. Are you all seeing anything at the hospital from the disaster coming in from...
Not yet. I think we're a little bit far. There's a wide variety of medical centers within a range of them. During Katrina, we definitely saw some, like dialysis patients and things like that. But I haven't noticed anything from as far away as Texas.
Well, the one reason that I ask that is, or say that, is I like to remind people, and it's kind of interesting, that we actually here, and I'm sure you're aware of this, we actually here in Columbus are an evacuation route destination for hurricanes. Did you know that?
I did not.
We are. Actually, if you go to the hurricane, in other words, matter of fact, we are for most of the panhandle of Florida, and even into Alabama. From Alabama, the coast of Alabama through the panhandle of Florida, if they have hurricane evacuation routes, that's why when there is a hurricane in those areas, and that we get a lot of people, all the hotels fill up, because this is actually a destination route, and because we have enough hotels.
Okay.
I've always wondered, who stays in those hotels. We have so many hotels.
I assume a lot of it is military, but because of Fort Benning.
But that's good news. I'm glad to hear that.
Yeah.
I'm going to give a little tease out there to everybody right now, because there's it's in the works right now, but about an 80% chance or better that very soon we're going to be back on the radio again, on that, the actual radio on that. We'll still be doing this all at the same time. We'll have all this stuff out there,
but we're a radio show.
Yeah,
we're radio hosts.
Yeah, and
we have faces for radio.
That's right, we do on that. I know I do on that, and we've got. And I also like to tell everybody too. I was talking to everybody when we were on the show for the Watch, and it's the same thing here. We actually are licensed journalists, radio journalists with the Secretary of State's office. And all of our guests and stuff like you are the same on that. We appreciate that.
And the information I put out is true to the truth, as best as I can tell. And when it's not, I'll usually say, better double check this or that.
Okay, well, let's just jump right into it. Okay, we're about to hit September, and I don't care what people say. I'm still of that generation. When you hit Labor Day, you're into the fall somehow, even though we're not officially.
Summer's over, right?
Fall, summer is over. Certainly fashion-wise, and but you hit Labor Day, that's it. You're moving in that direction and stuff. So, we're at that time of the year. Let's just start by saying. Needs of the public. Let's go back. Let's do the flu shots. The whole thing. Are there seasonal things that people need to do? Do we need to? We stock up on water and food, all kinds like that. Are there medical things we need to stock up for, if you will, for the upcoming fall and winter?
Not a bad way to look at it. And sure, people with respiratory illnesses and allergies, they definitely have seasonal patterns to them, and they're not all the same. Some people, do worse in the spring. Some people do worse in the winter with the dry, the cold, dry weather. So you should identify what your needs are, right, and be thinking about that. Oh, I don't have refills on my inhalers because I did fine in the summer, but fall and winter's coming, and my asthma acts up a little bit more. So, the good time to just make sure you have refills on your inhalers and allergy medications and things like that. So that one thing for sure. Any kind of respiratory or allergy things. Otherwise, flu shots, flu season will be upon us, and the CDC will be gathering data. Flu vaccination for the next season is not here yet, but it's something to think about in the fall. It's something you want to get your flu shot in the fall, so you should be thinking about that. And basic weather change.
Let me ask you a question, and I think a lot of people, I know I've had this question before, and I've asked you about it, but I'm going to answer it. I don't think we've ever asked it on the air, but a lot of people wonder out there. Okay, typically, people that take regular medication, and I'm not talking about narcotic medication, I'm talking about maintenance, heart medicine, allergy medicine, cholesterol medicine, stuff like that.
Right.
Not a class, classified narcotic or controlled substance by the government.
All right.
Other than that, very typically when you go to the doc, the doc gives you a prescription with maybe 4 refills or something like that. Okay.
Mm-hmm.
Let's say that you have, like I have, for instance, one of mine is Lantus. Okay, and I have a third. Let's say it takes 60 pills a month, and I have a 2-month or 3-month prescription on that. Can you ask a doctor? Is it legal to sit there and say, doc, I'd like to have 6 months of Dilantin, on hand.
We could do better than that. A year.
You
could go to your doctor.
Wow, I didn't know that.
You can say, can you please write me for a 90-day supply
Welcome, Pastor Harmon.
with 3 refills? So there, you can get up to a 12-month supply with 1 prescription. In general, we do a 6-month supply. The reason for that is every prescription medicine has a downside to it. And you don't want someone to go 12 months, with a problem due to that medicine before you see them again. So we tend to do give a prescription with 5 refills. That's a 6-month supply, and I'll see you back. But you can get up to 12 months.
But, okay, well, I don't know if that's exactly the question I was asking, because it kind of is. But let me ask you, okay, let's say, though, that I want to have 6 months of Dilantin stored in my or 3 months in my medicine cabinet. I don't want to have a prescription. I want to know for the next 6 months I have Dilantin on that. On that, can that happen?
Good question. I believe it can, because I know under certain circumstances, if you were going overseas for 12 months and you were stable in that medicine, that you could get a 12-month supply and bring it with you. And I know for a fact we write prescriptions for 90-day supply, which is 3 months.
Uh-huh.
So I believe that's something you could do at your pharmacy. Now, that I've never done it quite like that, but if you work it out with your pharmacy, I think you can.
And
as long as your pharmacist knows that the doctor's aware of it and you need it to have the 12-month supply. I don't believe it's illegal.
Well, the reason I say that is when you take medication, let's just say on Dilantin for a second, which is, as you know, because I know because I've been taking it since I was a kid, it's not something that you're not supposed to miss it at all or anything like that. And I'm and everybody goes, Joe Coley, what am I? I'm an Eagle Scout. I am. Be prepared.
Mm-hmm.
And let me tell you why I say this, Doc. Okay, because I've got a valid reason that I think a lot of people out there can have a valid reason. Hey, Neil C was joined. Welcome, Brother Neil. This is a valid point.
Mm-hmm.
We had a medication, and it was not a narcotic. That Pat has. Pat has quite a few. So I'm a heart patient. She's a pulmonary patient. She's a cancer patient, and there was some medication that she needed that she takes every month, and it's a relatively I don't even know what it is, but it's some relatively unusual type of medication.
Okay.
And we had an experience that really shook us to the core.
A mean pharmacist?
No, that's not what happened.
Okay.
Is we all of a sudden, now this is a drug, and to the life of me, I can't think of, Pat might can tell us, that, every pharmacy in town had.
Okay.
No problem. It wasn't expensive.
All
There's no problem with that.
All right.
And all of a sudden, we went to go get it, and they said, we don't have it. And then we started going, is there a generic? No. So we started going around. And all of a sudden, literally, now I'm not being facetious, we were at 4, 5, 6, the major ones, and then the specialty ones, even like Center Pharmacy and people like that, on that down there. And finally, I said, "Hey, what's going on? Why does nobody have this?" And they said, "Well, you know what? There are two companies, facilities in America that make this drug,
right?
And one of them burned down.
Yeah.
And so our you probably heard about this, and our supply got cut in half.
Yeah, I forget which drug it is.
And I can't remember what it was, but I said, so what does that mean? They said, it's going to be like 2 weeks before we have, unless you're in the hospital gets it first,
right.
And stuff like that, and that we were always told we could go to the emergency room.
There are national drug shortages any given day.
Yeah, and
there are shortages on medications.
And what's weird too? Let's go back in time a little bit, because this is kind of interesting. Because it's really the same thing on that. All right, here's a trivia question for Doc. On that, doctor, what? I don't do that one. That's silly. If you go over one of the free antibiotics, which we've already talked about you should be taking because they're on that. Not this drug, but too many antibiotics. Is Cipro. It's at a local place. If I'm saying Publix, they give you free Cipro. on that. Okay. Well, what's unbelievable about that? Well, a lot of people have already forgotten. I got a little humor here. I've been here all my life. In a few years, I'll be 60 years old. And I told everybody that all my life, 6 decades of life here, I've learned we have what's called the two-week rule in Columbus. The 2-week rule is that don't get excited if it's something that bothers you. Just wait 2 weeks, and then that 2 weeks nobody will even know. What are you talking about?
Yeah, wait.
Tax problem. What did we have? Crime. When did we have that? Is that so? Anyway, but do you remember back? A lot of people don't know what else. Here's my question: you, especially being a military, raised in the military as a military doctor. What else is Cipro used for? There's one other thing.
Anthrax.
Anthrax.
Yeah, there was no Cipro for a while. Yeah.
And Cipro is the thing that can
government
protect you from that.
Oh yeah.
On that. So all of a sudden, we had that anthrax scare. Remember, we had even here in Columbus. We had some white powder, and it turned out not out to be that. But there was
the federal government seized all the Cipro,
and the federal government went in and seized all of it. And then it was like. Seriously, it was like people were saying, like, you got Cipro, I mean, you could get $100 a tablet for Cipro because people were, there was
die of anthrax.
Yeah, because there was these anarchists that was, and it turned out not even to be legitimate. There was one legitimate amount of anthrax, and then after that,
some college professor.
We had some college professor did it, but then we had the copycats all over America. That were delivered. We had some here. We had a package delivered to the Miller Road main post office.
Oh, yeah.
It turned out not to be that.
Yeah, I worked in the emergency department around that time. We had so many people come in.
Scared to death.
You had people throwing away their cocaine because it was a white powder.
Yeah, absolutely.
The security guards at the hospital were like, we're finding little bags of drugs around because it's white powder, and everyone's afraid that
it's scared.
And they were getting rid of their cocaine even.
What is the only thing more dangerous than an actual danger?
Perception of
perception
right?
of danger. I don't know.
Yeah.
Hey, you know what? I'm going to claim that.
I
don't even know if anybody.
Well, there's a deterrent and a threat. The
only thing more dangerous than an actual danger is a perceived danger. At this moment in time, until somebody tells me that somebody said that before me, which they probably have, I'm going to say that that's the same for me.
Oh.
On that, but anyway, getting back.
Don't bother yourself.
But what's the point?
We'll be fine.
What's the point? That today, August 30th, 2017. Anybody can get Cipro. It's free over at Publix on that. Right. It's not even a charge for it. And it's, even if you have a charge for it, the other ones, it's like $4 or something like that, or some ridiculously low price. Right. So obviously there's a large supply of it out there. But we've seen in the past. So, I saw that happen, and then I saw it happen when Pat had this issue. And, it scared us. Doc, it scared us. We had to get a special order in from Atlanta. And so, and doctors always tell us, you guys always tell us, which is very, very, very pertinent, very appropriate advice, is do not wait down till you get down to like you need your prescription in 1 day. You have 1 day left.
Right, but it's one of your routine medications
because
you need.
Because sometimes you're going to go down there, and a lot of times we've had this happen.
Yeah. And
this is why I'm trying to get this to everybody out there, and you can validate this. A lot of people will go down there. I know I've done it. I'm going to raise my hand. I've done it. Or I've gone down. So I said, hey, I've gone to the wonderful people over there at Walmart Pharmacy on Widowsley, Bob and all the crew over there. We love them to death. And, it's not their fault if they go, it's a Wednesday. And they go, oh, we don't have any of that coming in until Friday. It's 2 days before we have that coming in because we have regular shipments, on Monday, Wednesdays, and Fridays and stuff. And then guess what? You're 2 days. So let's stop right there for a second because I've got a question. All right. And I think this is a legitimate concern that a lot of people have. And I know this is a very general term, but let's say this in general, mm-hmm. How much harm does it do when you're taking a medication and you skip a day? Or you say, well, I don't have the money for it. I'll get it next week. Go back on it next week.
Usually 1 day, not a big deal. You reach, in the body, you'll reach what's called a steady state. When you start taking a medication, mm-hmm. think of a ratcheting up. The first couple days, it ratchets it up. And then they're very well tested in your body. That's why some things are like micrograms, and some things are a couple milligrams, and some things are 500 milligrams. That's the amount of in there. And we know the amount, if you take the same amount every day or twice a day for a certain amount of time, your body reaches what we call a steady state level, meaning it ratchets it up, mm-hmm. and then it stays on a straight line as long as you take it every day. Mm-hmm. So if you miss 1 day, that steady state line might drop a little, but it doesn't drop to zero because it's still in your body, and you can pick it back up as long as the recommendation is take the next dose as soon as you remember to take it if you can. And then if it gets to be too late, just take the next scheduled dose. But you don't have to take a double dose the next day.
Let me ask you a question.
Go back to your routine dose.
Just, I don't know.
That's a general
statement.
General thing.
Let's just, I won't get into any, because I don't think it would be appropriate to get into any personal one. We'll just say, well, who I'm talking about. The major hospitals in town, do they still have the Ask a Nurse lines? Is that still in effect?
No, your insurance companies have that nowadays.
Because
not
you
the
know
hospital.
what? Well, and I would always say it's like in the analysis is that, and I try to tell this people, I know things cost money. I understand that, but I mean, if you really are scared, go to the ER, right? Go to the ER.
Well, it depends. That's a tricky question too. If you have a medical emergency, yes. But if you have something that's not a true emergency and you're just concerned, yeah, I would try to avoid the emergency room. Yeah. And get advice. Call your doctor's office.
It's a room of sickness.
Every doctor has on call. I mean, your doctor has to be available to you. And if he's out of town, someone should be covering for him. And if he doesn't have a way to address your issues after hours, then you need to discuss that with him or find another doctor.
We haven't said this in a long time, but I'm going to bring this up.
And there's urgent care.
Yes,
and ask a nurse.
And there's another place too. And you know what? And guess what? This is a wonderful group of people that are unsung heroes that a lot of people don't realize is that, and this is a fact, this isn't a Joe fact, this is a fact. Any fire station in town, any fire station, they're open 24 hours a day, 7 days a week, 365 days a year. If you start feeling, like you're having heart's going weird, or you feel like your blood pressure is crazy, or your blood sugar, or something, pull in there. They will check your blood sugar. They'll check your heart rate. They'll put the tabs on you. They will right there, free of charge. There's no charge for that, and they're happy to do it.
You can ask your pharmacist too. You can call a pharmacy, and there's 24-hour pharmacies. Pharmacists usually dispense good advice and dispense medications.
Great advice.
And Poison Control Center. If it's something that you might have taken or didn't take, Poison Control Center. So these are all things we should all have to avoid the overuse of the emergency room.
And and I'm going to tell you, Doc, like I said, Pat and I take, again, I'm not being facetious, probably 30 pills a day between the two of us on that. I'm sorry we have conditions on that. I'm glad we have. But you know what? I have had, again, Bob, the pharmacist out there at Winnesley Boulevard, Walmart, outstanding people. Mm-hmm. And this wasn't anything malicious. It's just what I went to Bob. They say to do it, and I showed Bob all my medications, and he said, "Joe, do you realize that these two are the same? Right here, these are exactly the same thing." And he goes, and I said, "No, I didn't. I don't know." He said, "Well, you might want to." And sure enough, I had changed family practice doctors, and it had just slipped by. And it was nothing harmful. And the doc said, "You know what? You don't really need to be on both of those." On that, because it's really redundant. It wasn't dangerous; it was just redundant on that, and that saves some time and some interest and stuff like that. But I have had wonderful experiences talking to the pharmacist where they ask a question, go in there and someone say, "I've got a toothache. What could I do for that?" I've had pharmacists save me tons of money when they went in and stuff and said, I've got my ear hurts, and I go like, "Oh, should I use this as swimmer's ear stuff? It's $9.95 a pack." He goes, "What is the little thing?" He goes, "No, just use a little bit of those little drops of something. I don't know what it was, but it was much cheaper.
Debrox or something,
something like that. It was much better."
Yeah, I always encourage people, walk up and down the aisles of the pharmacy, and you'll see how many home remedies and things you can, take care of that make your life easier without having to go through the pain and suffering.
I think too, something as a frequent flyer, I'm being a little facetious there to the doctor's office. Because of Pat and I, on that is, hey, when you're going to go see your doc, especially for a checkup or think about some questions before you go there, and maybe even write them down. And don't be afraid of your doctor. They're there to help.
Does your doctor make you bring your medicines when you go?
Yes, absolutely.
Most doctors want you to bring all your medicines every time you go.
And you know what? They're not going to slap you or something if you say, "Hey, doc, you've got me doing that one thing. I'm a little weirded out by that. Can you talk with me about it?" And they'll say, "Sure." And then you can say, "Are there any alternatives to that?" There are. And and what are the risks of that? What do you recommend? On that. And
if you catch them on a good day, they'll do that.
Yeah, on that.
Believe me, they'll be like, "Ask my nurse. We finished here." Ask the nurse on the way out.
And then what you say, and then watch this, he's not going to like this. And then what they say, when they do that, you go like, well, you know, when I was reading the HIPAA rules out there, it said that I could ask the doctor at any time. Has that changed?
Yeah.
And then they'll go, oh, no, it hasn't, actually. You please ask the question. And then and what number do I call if I have a complaint on that?
Yeah, the Patient's Bill of Rights. There is a thing called the Patient's Bill of Rights.
Patient's Bill of Rights, exactly, on that. You know,
I think it went along with HIPAA. I think it was passed at the same time.
You know, on that. But okay, well, getting back to what we were talking about is recognize that
we don't ever talk about one thing.
No, we talk about
we just jump around.
We're jumping around, but it's good stuff.
It's all hopefully. I mean, we hope people benefit from it. We figure our jibber jabber is same jibber jabber as other people's lives.
Absolutely. Well, thank you, Brooke. Brooke just joined us, one of my good friends out there. Go Troop 27 on that. Hey, Brooke, by the way, I need to call you because we need to get together for the troop business to get those things signed. I haven't forgot. Give me a call. But you know, one thing that is really neat too is that speaking of that, you know, in scouting, is that I work with a Cub Scout pack too. Is that, you know, I don't know what it is, but they're also some very simple things. And these are some things that happened last week is that both Pat and I because I have an irregular heartbeat, I take Eliquis, you know, to keep from stroke, which is a blood thinner, and Pat takes Warfarin, Coumadin, which is a blood thinner out there. And so both of us have to be careful about, you know, when we get cut, to keeping it cut, because even if I get a little bit of cut, it tends to bleed very profusely. And we had and I wanted to share this, Doc, because we had an experience. We were at a meeting last week, and Miss Pat had just, she went by a metal chair at school, and got just a little tiny, and guess what it was? It was a piece of paper, and she got a little paper cut. I mean, it was no bigger than your fingernail.
And it bled.
And it started bleeding. I looked down, and her whole leg down there behind her leg was what. Anyway, guess what? Now, how do you pronounce it? You know what somebody has suggested, and we had in her purse. I think you suggested it, actually. We had one of those, what do they call it?
Septic pen?
Septic pens.
Or styptic or...
Styptic, or however you pronounce that.
Yeah.
It looks like it's Greek or something like that. You know, where if you cut yourself shape,
right.
you wet it, and then you put it on, and it just stopped it.
Yeah, that works.
I mean, it just stopped. And so, you know, we went and bought like 4 more. They're like 98 cents. We bought like 4 more. We had one in the car. We got one in her purse. I got one. You know, we got one at the house and stuff like that. So, you know, those are some cheap, quick fixes. But, you know, I found out something, Doc. And it scared the chabibis out of me. Seriously. Wow. Pat had, I mean, I'm talking about the line in my finger, a little barely thin, paper thin looking little line. And I literally looked down, and the back of her blue jeans had a spot that big that was blood. And so I guess even a little tiny cut like that, you can get in trouble.
Well, when you're on anticoagulants or blood thinners, which is like Coumadin, Eliquis, Xarelto, Pradaxa, right? And then people are on the antiplatelet drugs, aspirin and Plavix. Any of those things, you can have excessive bleeding. If you have a nosebleed, if you have a bleeding from a hemorrhoid and you see bleeding in the toilet, and if you go to the dentist will be very adamant about being off all those things. And right, any simple cut will just bleed. Ooze. It's like an oozing bleed.
Let's go back to one of those that you said.
Yes.
Very common treatment, because I'm one of those too. Very common one that a lot of people do now is they take a baby aspirin every day that are my age on that. That's what that does, right? It thins their blood.
In a way, it inhibits the platelets, which in a way, you know, in layman's terms, yes, it's a blood thinner. It can cause you to have excessive bleeding. Like, so if you went to the dentist or you're going to have something done, you do need to hold off on it for a couple days.
Welcome, Emily, my old friend. I hope you're doing well.
But it's not it's not to the extent of
my high school buddies.
The anticoagulants or Plavix, but it can cause you to have excessive bleeding.
Well, you know, it's interesting. Emily coming on here because Emily was in the when many moons ago was in the dental field. I think she was. I had a person that I have a question for you. That asked me, said that is it true that you pain in your mouth or your teeth can be a sign of a pending heart attack? Is that correct?
In your jaw.
In your
you know how the classic pain when you get like you think you're having a heart attack and then it goes down your left arm. It can be if you experience it in your jaw, if it radiates to your neck or jaw, but not just like isolated. Oh, is this a toothache? Oh, maybe it could be a heart attack. Not like that. Mm-hmm. You could have just this annoying pain in your jaw, plus or minus the heart pain, but it's not necessarily like a toothache pain that would be confused with a toothache.
All right, and the same person asked me the same thing. Can you get can cancer come into your mouth?
Oh yeah, on that tongue, gums, your tongue, your tonsils, the roof of your mouth. You can get tonsillar cancer. You can get cancer in the front of your tongue, the side of your tongue, the back of your tongue, way back in your tongue. You can get cancer in your voice box, and yes, oral cavity.
Is it a true statement? I heard sometime back, Pat and I heard that all human beings have cancer cells in their body. Is that true?
At some time in their life, almost yes. We have abnormal cells that undergo genetic mutations, and our body's immune system carries them away, destroys them and gets rid of them.
Okay, let's talk, and I hate to be this direct, but let's talk about that for just a second, about stupid things, I'll call that, on things you can do to get cancer. That if you want to enhance your of course, smoking does that on that, and of course, and then chewing tobacco. That's definitely you're no less of a risk, right? And that I have a family member that has throat cancer because of that.
Yes.
And, matter of fact, we have a friend out there that's watching right now. That's not on the list here. That has a family member that died of that. All right. Okay. Let's get back to being predisposed. My wife Pat's sister died of breast cancer. What is the level? What's the correlation between cancer and hereditary, having genetic in your DNA on that?
There's a certain percentage of breast cancer that does run in families, and some of it's higher, and that's when you can get the genetic testing. But not all breast cancer will go down in between the families. So if you find out premenopausal breast cancer in grandmom and mom, that means you should get your genetic testing.
And for guys can get it too, right? Guys can get breast cancer too.
Yes, men can get breast cancer.
And they die of it.
Yeah, it's very rare.
It's rare, but it does happen. On that, let's stay on that just a second. I've heard a little bit about that. What is there tests now that can be done to say whether or not you are predisposed to get cancer?
Yes, and in women especially, there's not a lot. There's a handful of tests that can be done, and one of them is that BRCA testing, BRCA1, BRCA2, can detect a woman's chance of getting breast or ovarian cancer. And the poster child for this, like it or not, is that Angelina Jolie. That's what she did. She had a bilateral mastectomy to prevent cancer because her mother died of ovarian cancer when she was very young, and that scarred her for life. And she didn't want her children to do it, so she had it tested for it. And she actually did carry the genetic risks for it. And she was such a high risk to develop breast cancer. And I'm not sure if she had her ovaries removed or not, but she had both all of her breast tissue removed without ever having any breast cancer as a totally preventive thing. That's the one example.
Breast removed.
Yes. Now sometimes they can preserve the skin around it and even the nipple, but all the breast tissue has to be removed. And then she obviously got reconstruction. I mean, like I said, she didn't have cancer, so they weren't under pressure to get it done quickly. They could take their time, and I'm sure she spent a lot of money on the plastic reconstruction of it. But that is one area where you can do something totally preventative to find out, that you're predisposed to cancer. Other than that, there's not a lot of good examples.
I want to bring up a couple positive things that just happened in our own family last week that certainly we can do a recommendation for. For those of you who, one of my dear wife Pat, I wish she was here right now. One of her things issues that she has are she has pulmonary disease and does have, thank God it's under control right now. She had renal cancer, but she also has severe degenerative arthritis in her knees. And she had, this last week, a wonderful doctor, Dr. Oglesby at Nexus Pain Clinic. I am giving them a not compensated endorsement, but I'm giving an endorsement because I like him. And he gave her a cortisone shot in her knee,
Mm-hmm.
which was not really that. It didn't really hurt that bad, she said, but it was sore for a day or so from where the injection was. And she has said that at least now, temporarily, for however long it goes, that it did like 100% reduction in the pain.
Yeah, injection in joints, you have to be careful. It's what we call like law of diminishing returns. The first time it might be great, next time not so great. Every time you inject into a joint, you risk having infections or bleeding, and while it does, help with the pain and everything, it can lead to other problems in the joint with your ligaments and everything. So it shouldn't be done frequently, just on rare occasions.
Now, let me bring up, and we didn't get a chance to really talk with him, but maybe see if you're familiar with this. He did bring up, and that he said she is a candidate for this, and this was fascinating to me because it gets into stem cells kind of thing. He said that there is a new procedure, an outpatient procedure,
Mm-hmm.
where in the office that he goes, uses some sort of deadens pain and uses some sort of a device and actually takes a bit of I guess, matter from her hip and then injects it back into her knee.
Well, you might be talking about PRP, which is platelet-rich plasma, where they actually just take some of your blood and they spin it and they get the platelets. And
no, this was something out of her hip. Definitely out of her hip. He definitely.
Well, I'd be very careful about that. I don't know. I would ask for all the specifics on that. PRP though.
I was surprised too that he said it was outpatient. That is.
Yeah. Well, but I mean, PRP is much more acceptable, which much better results in these things. I'd be very careful about what he's talking about doing. I'd research it good because we're just not there with stem cell treatments. We are not there. And, going into her hip, that means they're trying to get into her bone marrow. They're going for a bone marrow aspirate.
Yeah.
And I don't know if there's a good evidence that does a whole lot of good.
I appreciate that second opinion on that. And now I'll tell you another thing that fascinated me. I was speaking last week to not the young, but Mrs. Dr. Chokar. Actually, I wasn't speaking to Dr. Chokar. I was speaking to somebody who had talked to Dr. Chokar. And Dr. Chokar was telling this person, Paul Morris, there's nothing wrong about it, that very recently, I guess it was a week or two ago, that she had put a pacemaker in a 96-year-old man. And she was saying, wow, that's unusual. She said, no, that today, that what it would be 20 years ago, that would have even been considered because of the age. And now that even if this person can get another year or two of life, that it's a totally acceptable procedure. And I can remember in my teens, in particular, well, no, my teens, my early 20s, which would have been in the 1980s, I had an uncle who's passed since, but had from smoking since he was about 8 years old, had severe emphysema, and to the point that they had said that he needed and then let's skip forward to, I think he was very early, maybe 70 years old, 69, 70, and that they had said that he needed a lung transplant, and they said he was too old, back then, that they would not even consider that at that. But this is 30 years ago.
Well, and transplant is different. Like this same man, if you needed a heart transplant, they would tell him no. But it depends on your functional. If you're 96, if you're otherwise functional, you don't have severe dementia, but for your heart beating too slow, you could live, a productive life. Then it is a reasonable thing to do. If you're 96 and you have lung disease and you're on oxygen and you're in a wheelchair, or you have cancer, then you'd have to say, no, that is not a wise decision to do in that 96-year-old. So each human being should be looked at individually for that.
Also, right now, I passed on there, but if any of you out there have a question, you can write it in on the comment section right here. It's on our Facebook section. If you have a question here, we can get Dr. Clark to answer that for you. But what we're basically getting around to too is, and then I need to go to the second question that somebody asked me to make sure that I asked you. Okay.
All
right. What, in your opinion, as a medical doctor, I was asked to ask. This is a person that's considering, was told that they, by reputable people, that they've been wearing glasses all their life, that they were a candidate for, I guess, laser surgery, where they would no longer have to wear glasses or have contacts of any kind. Is that a very common thing now today?
Oh, very common. Now,
what do they do?
but they reshape the cornea. The laser beam affects the cornea. It scars it in a certain way, and it reshapes the cornea, which is all the lens does. It just changes how the light goes through the cornea. It just changes the shape of the cornea, so the light focuses on the back of your retina better.
Yes.
So that's LASIK surgery. It's very common. However, they'll tell you now, I'll correct your far vision now, but when you're 40, you're going to need reading glasses. So it doesn't prevent you from needing reading glasses later in life. So you won't be out of glasses the rest of your life.
Well,
just for your short term.
I went down that road. I went down. Let's see. Like I said, I'm 56, and I'll be 56 in January. And I started with reading glasses, and then now pretty much I can see without my glasses, but I can't. It's blurry on that, and I can't read anything, and my eyes start bothering me when I don't have my glasses on now. So I
don't know what insurance covers it though, but it's a very safe procedure.
And I have trifocals. Should that tell you?
I think most people nowadays have multiple level things. But the safest is glasses. Contact lenses bring their own set of problems with them, and then laser. And it's a personal decision you make. You sit down and talk to your eye doctor and come up with what's right for you. They're all good options.
And the third question I had, which is from a family member that has a 3-month-old, that said this first child, and has been doing some research and stuff, and said, I'm remembering in my head now, Doc, my question is this, is that I've been looking over the past 30 or 40 years, and for a period of time they said, put my baby on their back, and then they changed, and some said, no, put their baby on their stomach, and then now they come back and stuff and said, it's okay to put them on as long as their arms are back. Like, do you have a thought on that?
Well, when I was training, we were clearly in the mode of back to sleep. There's an increased risk of SIDS if you lay the baby on their stomach. And it used to be, well, if they're on their back and they spit up, then it'll all get into their face.
She asked me about that too. I forgot.
But
SID, let's talk about SID, sudden death infant syndrome.
Yes.
Sudden death infant syndrome. What exactly? Do we know what causes it?
No. We only know risk factors. We still do not know the sudden death thing. Whether there's a gene or predisposition, we know it's higher if there's people who smoke in the home, but we don't know for sure. But it was always lay on your back to sleep. Now, I think there is some wedges, for the side. But and if it hasn't changed, it was always lay your child on their back to sleep. Back to sleep.
Back to sleep.
Yeah.
Back to sleep. Okay.
There's always research on that, but that's the I'm still very certain that's the recommendation.
Okay, and finally the question. I think this is a little bit racy, but that's all right. We can do that. We'll all be adults here. I had somebody that has an 11-day-old that asked me and stuff and said, "What is your opinion of circumcision?" That's changed.
Yeah. Well, it's not medically necessary. It's for hygiene only. Again, that's a personal decision. I think there is more and more going uncircumcised. So there is some evidence that there are some benefits to not circumcising, as long as you learn how to deal with the retraction, because there are some serious problems you can get later in life if you're uncircumcised and you're not just performing routine, what we call hygiene, retraction and cleanliness and things like that. Mm-hmm. But there's no medical reason to get a circumcision.
Mm-hmm. Okay. And finally, the last question that I had was this: is that is there a what do you think about pasteurization? They're going back now, saying that go back to the old non-pasteurized stuff, and because all it is nuking it and it's bad for it, or whether it be. Would you have a thought on that?
Well, the process of pasteurizing, saved lives, right? Louis Pasteur, the great microbiologist and chemist, came up with the process of pasteurization because people can die from bacterial overgrowth in milk or other things. So, yeah, I think we need to pasteurize. Now, what you're talking about is going back to raw. Now, you can do that if you're on the farm and you're picking it out back, or you're milking your goat and you're having it for breakfast. That's fine. But as far as storing and packaging and going out into the masses, we need pasteurization.
Absolutely. Okay. Yeah. Interesting on that one. And that again, I happen to see, and this is that's the question you asked, but I have a question for you. I was fascinated by something that I saw last night, and I wrote it down. Actually, I have it right over here to ask you that. I don't exactly know which. I don't know if it was the EPA or if it was a government agency that deals with this. Came back and stuff and said that the level of concern, according to this government agency, that in the United States, that now that almost 50%, that's huge, of the freshwater drinking sources, whether it be below ground, on that, rivers, whatever, over 50% of them are carcinogenic, have chemical to various levels, but that that they, to the point where they're almost the point of they're saying that if you get water, you need to get a filter of some kind. Everybody should have a filter in their house, and then you should filter your water. What do you think about that?
I don't know if I agree. I mean, it could be. But I think in general, public water systems is relatively safe. Drinking water, they're tested for these things. Yeah, are there low levels of different carcinogens in there? I'm sure there are. Yes, but to the point where we really have to be that concerned about it, I don't think so. I feel safe with tap water from a public system. Now, there are not without their problems. There has been major infections in big cities with cryptosporidium, some kinds of spores that get into the public water system. And of course, this nonsense that happened up in Detroit. And that was all due to their previous motor vehicle industry with the lead. They still had all the lead getting into their drinking water up there, and they didn't do anything about it. But in general, it's very safe.
I thought it was very interesting. As one of the, I saw remember it was Steve Emby, one of our former rare guests on the show, that's a EMT instructor, very qualified person, was saying that he was very concerned about the people in Texas with the floods there. That because when you have the floods, of course, it overflows all the sewer systems, and then it gets into the older cemeteries where they're infiltrated and germs and bacteria come out.
Right.
That basically, that's going to breed, and then after that, when it goes down, it's going to bring mosquitoes and all this.
And the sewage overflows into the reservoir, so
it's going to be, really, even when the rain stops and everything starts going down, we've still got a very bad situation there.
Yeah, now that, and in general, I'm a fan of water filters. I'll be honest with you, my main tap in my house, I don't think we have a filter on it, but I think a water filter is an easy thing to do, but the things that they have. I'm much more proponent of water filters than buying bottled water. I think
I actually, being an Eagle Scout, I know the answer to this question, but I'm going to ask you for everybody out there. So, is it true that virtually any water, almost no matter how nasty it looks or how bad it smells, if you boil it and you boil it thoroughly, it kills everything in there?
I'd say yes.
Yeah, and that's what we were always taught.
Yeah, if you can boil water, you're good.
That if you have that, you have enough of it because sometimes it's going to burn off. But you boil it long enough. I think it's. I believe it's like 20 minutes or something like that. I don't know what it is if it's really bad on that. But I've seen some people that in the service that had some just horrific stuff and boiled the kajangies out of it, and they took it out and did the little test and said there wasn't nothing live in that stuff. On that. Yeah, it's interesting because when you get into that, you'd be surprised. We support some children and families over in Africa, and there are a lot of countries in Africa that have the number one, contrary to what people think, the number one problem in Africa is not food. That there are many countries. That's only a few countries on that. There are countries that have plenty of food over a bunch, but have bad water.
Yeah, clean drinking water
is a major area of concern. I hear that we're back to the West Nile virus stuff again too, or the mosquitoes again.
Well, that's usually in summer from the mosquitoes, And notice we went through this whole summer. You didn't hear much about West Nile virus. We didn't hear much about Zika virus.
Zika kind of slipped by. It's that 2-week rule. And it 2 weeks.
Something like that, yeah.
We were all excited about it.
But we didn't know. But we were prepared though. It was on our mind. We were prepared for it. Pregnant women took precautions. The DEET sales, I'm sure, went up. The DEET people were probably very happy. And we got lucky, I guess, too. And it could have something to do with weather patterns. I don't know what all the studies are, but there were plenty of people who were exposed to Zika and tested positive for Zika. I don't know that many pregnant women. There was probably only, very few pregnant women that developed Zika infection while they were pregnant, and of course, their babies are probably just being born around now if they were exposed last summer. So we'll wait and see, with the Zika, if there's any birth defects.
Well, we're getting ready to close out in just a second, but one thing I'm going to bring up is interesting that we're talking about, we'll have to wait and see. Is I was also reading a study this last weekend, which is really interesting. Is that in order to do using scientific method to do a proper study, we really don't know. We don't have enough hard data because cell phones are relatively in the scheme of time is a relatively new thing, and we don't have enough data yet on does holding a cell phone up to your head cause problems, does it not? There are people there's wide-ranging opinions on that. But the bottom line is that that will be interesting, but it's probably going to be 10 more years before there's enough cumulative data for somebody to come back and go, "Ooh, gosh, you shouldn't have been using those cell phones."
Well, there should be a limit, so many hours per day or whatever. But the average use right now, I don't think there's any immediate risks.
Man, you must not know any of my kids, because my kids probably keep AT&T,
well, that's
and Verizon and T-Mobile in business.
I agree. Once your nervous system is formed, it's not as bad. But if you're talking about children and adolescents, whose brains are still forming, and they got that much electromagnetic radiation.
I got a 4-year-old granddaughter that uses a cell phone. On that. But
I believe they're looking at it, but it's a good topic. We should talk about it.
We'll talk about this more. Thank you for coming on the Radio
Great to be here.
Show, the Medical Hour here. And you hear Dr. Clark every Wednesday from 2 until 3 p.m. Here. And we've got some good news coming for some new things that we're going to be doing. And we sure appreciate it. Stay healthy and stay safe. And God bless you and God bless America. Thanks, Doc. And Miss Pat, will you take us out, please? Thanks, Doc. Appreciate it.
All right.
We'll see you next week. Okay. Bye-bye.
Thank you.